Hello, everyone. I'm Donatella. I'm the Executive Officer of Northern Volunteering, and I'll be your facilitator for today's webinar. Northern Volunteering SA is collaborating with Palliative Care SA, Volunteering SA&NT, and Southern Volunteering to administer the Palliative Care Volunteering SA project. This project is funded by SA Health and aims to champion palliative care volunteering across South Australia. We're delighted to have you join us for the Palliative Care Volunteering SA Establishing Roles Conversation Series. These are a series of conversations with different volunteer coordinators where they kindly share their knowledge, experience, and learnings regarding different palliative care volunteering role categories. These sessions are aimed to provide an introductory overview for volunteer coordinators who are interested in establishing roles within these categories. We are aware that all volunteering organisations are different, and the experiences shared within these sessions are to be viewed as examples and guidance only. Before we commence today's session, I would like to acknowledge the traditional custodians of the land and recognise elders past, present and emerging. I'm currently in the beautiful Kaurna lands of the Adelaide Plains. Now to this webinar. Today's webinar is on palliative care volunteering roles that come within the category of companionship and social supports. These roles can be found in the following volunteering organisation settings: client-facing, which is inpatient, facility, hospice, residential, aged or disability, inpatient-based, or client-facing, either home or community-based, community-based. I'm delighted to introduce you to our guest speaker today, Gemma, who is the Palliative Care Volunteer Coordinator at Central Adelaide Palliative Services, CAPS. CAPS has a well-established dedicated palliative care volunteering service, which provides roles in the following settings: client-facing, inpatient, facility, hospice, residential, aged or disability, inpatient-based, client-facing, home and community-based, and non-client-facing. Gemma has worked with CAPS for nearly 6 years. Before CAPS, she coordinated the volunteer service at Purple House, an Aboriginal-owned and run health service based in Alice Springs, providing dialysis in remote communities. And Gemma has a Bachelor in Community Health. Welcome, Gemma.
Thank you, Donatella.
Gemma, can you please describe the different types of volunteer roles you have that provide companionship and social supports, those within your volunteer service, and also provide a summary of what a volunteer shift might look like?
Yeah, so I guess in terms of companionship, they would fall across both our community volunteers and our ward volunteers. So on the ward, it would be spending time with patients and their families or their loved ones, just being a listening ear. It can be really lovely for some of our patients on the ward who maybe don't have family or friends within Adelaide or close by, so they're not getting many visitors. That can be a really lovely thing. I think where we see most of our companionship and especially our social support volunteering is in our community team. So that's where patients are visiting. Volunteers are visiting patients in the community in their homes or taking them out for a coffee, helping them with their shopping, maybe taking them to appointments. That's where we really do see that, I guess, the social support aspect coming into it, as well as that companionship. It can be, again, a really good thing for patients who maybe don't have a lot of support in their lives. We do find that most of our referrals come through for patients who are maybe a bit lonely, quite isolated, and it can be a really meaningful and impactful service to provide for them. So in terms of a typical shift for our volunteers, it obviously does differ on the ward and in the community. On the ward, the volunteer will be coming into a very, I guess, well-oiled machine that our wonderful nurses and medical team and as well as our psychosocial team create on the ward, and they're able to liaise with the staff around who might best benefit from having a visitor that day. And, maybe someone who might really appreciate having a chat, someone who they can go and get a cup of tea for. We gifted quilts by a beautiful quilting organisation, and our volunteers are able to gift those quilts onto the patients on the ward. And that can be a really great, in for kind of introducing themselves and opening the door up for conversation. For volunteers in the community, it will be going to the patient's house, and whether or not, I guess it depends on what the visit is for. So it might just be that they'll be going to the house, having a cup of tea, having a chat, just being some company for the patient. Could also potentially be providing some carer respite for carers as well, an opportunity for carers to get out and have a break themselves. But some of our community volunteers, it will be maybe picking the patient up, taking them to the shops, helping them with their groceries. It could be that they want to go to a cafe and have a coffee and a chat. So it can really vary, I guess, patient to patient.
Is there any specific training for this role that you provide that is different to your usual volunteer roles?
Yes. So I guess we do have our usual introduction to palliative care training. That's our 2-day training that we provide for all of our volunteers. But then on top of that, we also do an orientation specific to community volunteers, as well as we have a ward volunteering orientation as well. So that's where we can get a bit more into the specifics of that role and what the processes are that are involved in that role. And that's done with me one-on-one, or if there's, a group of volunteers starting at the same time, sometimes we'll be able to get a few in and do it all together. But a lot of that is, around referral processes in the community, processes around what the visit might look like, the scope of the role for both volunteers in community and on the ward. So I guess that's where we can start to put in place what boundaries are for volunteers, and where is the point where it's important that they're reaching out to myself or someone else in the team for some help or for some, next steps for care around the patient. It's where we do a lot of our paperwork, things like getting their security ID. We can go over safety and emergency procedures, what the documenting process is, and also, reiterating the very open door policy that I have around debriefing with volunteers after their visits in the community or on the ward.
Thank you. Where do you usually advertise for these types of volunteers, or how do they hear about the role?
So it can really vary. We do try and do some recruitment drives throughout the year. So that's where we'll be using the volunteering SANNT Victor. And then from that, that's where the ad will go on to Volunteer Seek. So we do get quite a bit of interest coming in from that. We do also work closely with Palliative Care SA, the volunteering project, and they're able to also put out ads that we are looking for some volunteers for our service. And sometimes that will be that we're looking for specific roles, whether it be community volunteers, ward volunteers, biography volunteers. And then, we have also at times put up flyers at local community libraries and community centres. Looking at demographics that maybe aren't on the internet as much. And we also get quite a few volunteers through word of mouth as well, which is really great.
And are there any specific skills or experience or qualifications you actually look for during recruitment?
There isn't anything in particular. There's no kind of you need to have this qualification, or that you need to have had certain experiences. I would say the most important thing that we're looking for are people who are compassionate. And I do think that, we are looking for people that have a bit of understanding and I don't know if comfortability is the right word, but perhaps some comfortability around the fact that it will be a role that involves working with people with a terminal illness, and that death and dying are a part of this service. And that's just us wanting to make sure that people are well supported, and that it's a safe environment for a volunteer to come into. We do, of course, do our national police clearance and working with children's checks, but we can do that in the onboarding process. It isn't something that's required to apply. But really, it's just making sure that it's a good fit for them. It's a good fit for us. And yeah, we've been really lucky. We've had people with all kinds of different skills and experience. We do have some people who have been nurses, or we have people who are currently social workers, but also everything in between. We have some students. We have people who've kind of lived very interesting and different lives. So it's definitely not a one size fits all. That's what we want. We want people from all different backgrounds to be able to join.
Thank you. And how do you actually receive referrals for new clients who could actually benefit from a volunteer in these roles?
So on the ward, it's just a day-by-day situation. Again, that's liaising with the nurses and the social worker there on the ward. So volunteers on the ward know kind of who they go to when they start their shift. But in terms of community, because it is a bit of a totally different can of worms, our referrals come through from our community team. So that's usually our community social workers or our community nurses. And so they've, I guess, been able to identify that there is a situation where a volunteer could be beneficial for the patient and their family or their loved ones. And it also, I guess, allows for just gauging the situation, making sure that it is actually a safe and appropriate place for a volunteer to go. And again, also that it's something that the patient and their families are wanting. It's not something that we're kind of thrusting upon people. It's very much an opt-in service. So yeah, our referrals come through from the community team. They then come to me. So I have a standard volunteer referral form that covers everything from basic patient information, relevant social situation, things that are good to know, like, are they speaking languages other than English? We check if they've got an advanced care directive. That would be important for a volunteer to know in case of an emergency situation. And it also identifies what the reason for the referral is. So whether that is companionship and social support, whether it's respite for a carer. And then there's a little bit of, relevant information in terms of hobbies, interests, just things that are good to know about a patient. Once I've received the referral, I'll then call the patient and or their carer or their family, and I'll check this information, and I can then explain what the volunteer service is in a bit more detail, and then that's also the place where I'm able to put in, what the boundaries or the scope of the role is. I can discuss things such as what the emergency procedure is if there was a medical emergency while the volunteer was there, all of these types of things. And we also have our community risk assessment, which is done by either the social worker or the nurse. So there's a lot of safety checking, I guess, involved within the referral process, but definitely coming from our community team.
Thank you for that, because the second part of the question was, what information do you usually need to ensure the referral is appropriate? And
Yeah.
you've answered that. That's great. And then you use that information to match the volunteer to the client.
Yeah. So I think that is an important part of it as well. You want to, I guess, make sure that it's a match that
Mm,
people are comfortable with. And, of course, it's not going to be that, oh, these people are both Port Power supporters. This will be a great
mm,
match, although that has happened before and it does
mm,
work well. But, just making sure that, yeah, it's I guess, a safe situation for everyone. And when I say safe, I'm talking culturally safe,
mm,
emotionally safe, that it's just a comfortable situation for everyone, as well as the, obvious kind of, I guess, safety things that we're looking for. Um, I guess the other thing is that when I do call up and do my own assessment after I've received the referral, that sometimes it might be that the family and the patient have had to think about it and they decide that they don't want to move forward with it, and that is absolutely okay. As I said, it is something that we want it to be an opt-in. We want people to want the service.
mm.
Yeah.
Thank you. Now, you did touch on this right at the beginning, but can you briefly describe what a volunteer shift might look like for a volunteer undertaking the role in this area? So, what's a day in the life actually look like?
Yeah, so once the referral process is completed and the volunteer has been placed, excuse me, the day before the visit, they'll typically call the patient or the carer just to check in and make sure that they're still up for the visit.
Mm,
That is something that does come up from time to time. It could be that, oh, sorry, we've actually got a last minute appointment. Um, Actually, the patient is not feeling very well, is a bit tired. Could
mm,
we just go ahead with the visit next week or next fortnight? So it's just to check that they're still happy for the visit to occur, and uh, yeah, just to also can be a gentle reminder as well. Sometimes for palliative care patients, they might have a lot of different appointments, a lot of people coming
mm,
in and out of the house for different reasons. So it can just be a good way to say, hey, I'm the volunteer from CAPS, and I'll be coming tomorrow. So in terms of their actual visit, they'll go to the patient's home. And before they enter the home, they do a safety check-in with me so that I know that they're at the house and that the visit is about to start. And then, you know, they'll conduct their visit. And as I said, that can be a number of different things, whether it's just a cuppa at the house or taking them to do the grocery shopping or anything like that. And then once the visit is finished, the volunteer will do another check-in with me so that I know that they're safe, they've left or are leaving. And then there is, I guess, the kind of reporting or just the notes on the visit. So that's an opportunity just for them to say, I visited this patient, we did X, Y, and Z. They can also put in observations that obviously are not clinical, but it's again all within the confidentiality of the service as well. But they can make observations like, oh, the patient did seem tired or things like that. They are able to just put that in there just for, I guess, point of reference. That is something that we are able to um, provide the feedback to the team if necessary, if there's anything concerning that pops up. And then there's also always the opportunity for a debrief with myself after the visit. So it can just be, hey, everything went really well, really enjoying, this kind of
mm,
latest assignment. But it could be, hey, yeah, it seems like the patient is having a bit of a hard time, or um, you know, it could be any number of things, but it's just an opportunity for the volunteer just to talk through what the experience was. And if there's anything that needs to kind of be followed up, they can then know that they've left that in the hands of the volunteer coordinator. Um, and then I can pass that information along
mm.
if required. So that's a typical shift in the community. Yeah.
And what challenges have they've been specifically around having volunteers in these roles. And you mentioned boundaries already. So how do you actually manage boundaries, documentation, reporting back, debriefing with volunteer in these roles?
So I guess in terms of challenges, probably one of the biggest things is the unpredictable nature of working with people in palliative care.
Mm,
So, as I said, it could be that a visitor's all organised, a patient's kind of ready to, a volunteer is ready to go and visit a patient. Um, but it could be that, yeah, something as simple as the patient isn't up for the visit, they're just really tired, they're not feeling well, maybe.
mm,
Could be that the patient has gone into hospital overnight. Could be that the patient has passed away. And sometimes that can happen, with not much notice. And, sometimes the information hasn't gotten to the team for us, then the volunteer know. So, yeah, I guess that is just the nature of working with people with life-limiting illnesses. And I guess it does, being a volunteer in this role does require a certain level of flexibility, and that
mm,
sometimes, yeah, it could just be that you could be really excited about meeting a new patient or getting to go and visit a patient that you've seen many times, and that there can be disappointment in that not going ahead. Um, but also that, grief is also something that can come up, especially for volunteers who are working in the community. They've been building a relationship with someone
mm.
for a long time. It's very natural to feel grief when they do pass away. So that is something that does come up, and we work really hard to support volunteers with their grief. Um, Other challenges are something as simple as going to someone's home for the first time. It can be a bit awkward almost, or it takes a lot of confidence
Mm,
to kind of without the environment and support of being, say, in a hospital situation with our ward volunteers who do a beautiful job. Just to be going to someone's house by yourself for the first time, knocking on the door, it can be quite daunting, especially for new volunteers. So that can be a bit of a challenge, I think, for some people. Um, I guess also that there can be unexpected situations, quite rarely dangerous situations, or what could
mm,
become dangerous situations, very, very rare, but it is the world that we live in. And again, if there's not that kind of protective environment of being in a hospital where there are lots of other people around who are trained for medical emergencies, for there's security and everything here.
mm.
Again, it's a volunteer going into a home by themselves. So it is just something that we do always need to consider, even though it is, touch wood, a very rare situation. In terms of managing boundaries, the documentation, reporting, debriefing with volunteers, I think that boundaries are it's probably one of the most important things that we can provide volunteers. It's one of the most important things we can provide the patients and their families. And it's also really important as the volunteer coordinator to be clear on those boundaries with other members of the team who maybe, because they're not working in the volunteer space day in and day out, they might be making, referrals, you know, every other month or something like that for each worker. So they might have an idea of what volunteering could be or should be. And it's the volunteers coordinator's role to just say like, hey, this is what the volunteers are actually able to do. And these are
Mm,
the reasons why we can't have volunteers um, moving couches around the house. And these are the reasons why we can't have volunteers doing personal care for patients. And these are the reasons why we can't send a volunteer to say, a volatile family environment where perhaps there's, you know, just unsafe situations around domestic violence or substance abuse issues, things like that. It's just, it's just really the most important thing that we can do within the role. I guess in saying that though, it is really important for volunteers to be clear on the boundaries before their visits, and that does come in with their training and their ongoing support. But I also think it is really important, especially for community volunteers, to provide a space where, hey, we do know that you're out there on your own and you have to make decisions in real time if something unexpected comes up. And even if in that moment you don't maybe do exactly what you're meant to do, we can still support you and we can kind of talk through that situation, and we can, you know, I guess from an improvement standpoint, look at what we could do as an organisation to better support volunteers in that space. So, you know, trusting your volunteers as well within those boundaries. As I said, the nurses and social workers, if they're making the referrals, they are able to, I guess, give a bit of an overview about what the volunteer role is. And then again, when I come in when I'm doing my telephone assessment, within the referral process, that I'm again able to really put those things in place. Volunteers aren't to administer medication. Volunteers can't do manual handling tasks. You know, assessing, you know, is it a safe environment? Are there animals in the house that, you know, maybe need to be put outside? Does anyone in the house smoke? Please don't smoke in the house when the volunteer's there. Things like that we're able to put in place. And then I think the reporting back to the volunteer coordinator and the opportunity for debrief, I do really think that this is, it's just really vital to so having a sustainable community volunteer service, again, because they are just there on their own. It's just really important that they have that opportunity to just talk things through. And it doesn't necessarily have to be that there were any problems or any issues. It could just be, hey, that was a really good visit and that felt really, really cool to do this thing with that person, or yeah, talking through maybe they're witnessing the kind of physical health decline of someone and the challenges that come with, I guess, you know, witnessing that happen in real time and all kinds of things. It's really, really important that volunteers feel that they can have those conversations, and they can be informal conversations as well. It doesn't have to all be, you know, there's a set of questions or you know, writing things down. It can just be an opportunity to talk it through. And then we also have our peer support, volunteers supporting volunteers, and that can happen at our volunteer meetings that we have quarterly as well.
Excellent, thank you. Is there any specific equipment or supplies or out-of-pocket expenses or costs that usually come with these roles?
There aren't too many out-of-pocket costs. We do provide mileage for community volunteers, so for driving to and from the patients' homes. And I believe that at the moment is $1 per kilometre driven. So we have a whole process around that. So that is something that volunteers can be reimbursed for. You know, if volunteers are going with a patient out for coffee or taking a patient to do their grocery shopping, they're not shouting the patient the coffee or the groceries. That is all, you know, coming from the patient, and that again is all kind of made clear within the referral process. We do provide things around like hand hygiene, so hand sanitizer, you know, in the height of COVID, we were providing masks. So, you know, just things like that. But for the most part, there isn't any, I guess, specific equipment or, yeah, any equipment that's really required for the community role.
And if another volunteer coordinator was thinking of including these roles within their volunteer program, what advice would you give them?
So I would just say to create a clear role for the volunteer so that they understand what the expectation is of them, and also what they can expect from you as a volunteer coordinator and from your service as a whole in terms of support, training, things like that. Again, creating the clear boundaries with the patient and the family, just having everyone on the same page, including, you know, paid staff of the palliative care service. Understanding that things aren't black and white. I did touch on it a little bit before, but sometimes unexpected things do pop up, especially for volunteers in the community. So an example of that would be that a patient could be with a volunteer out for coffee and they might say, hey, can you duck into that shop and grab me some milk and some bread? Here's my card. We do have a process for if a volunteer is doing grocery shopping and there is exchanging of money or card between the patient and the volunteer, just to make sure that everything is above board and documented and everything. But, you know, if a volunteer said, look, I did just take their card and I did get them some milk and some bread and I gave them the receipt, it'd be like, okay, that's all right. Maybe I can, you know, I'll send you the form, our finance form that we do. And then if that happens again, you'll just have it on you. So we just know that for next time, everything is as it should be. But sometimes, yeah, unexpected things do just happen. Could be something like taking a patient to the hospital in an emergency. So that's more of a high stakes issue, I guess, that could come up. Again, you know, we do have an emergency procedure, which does involve calling the ambulance. But if a volunteer assesses the situation and says, you know what, we're actually 2 minutes from the hospital, the patient is in my car, they're able to get into my car, they're able to get out of the car to emergency room. It's just about supporting them in that process and unpacking it and debriefing it. So having boundaries in place, but things aren't always black and white. Trusting your volunteers and supporting them. They're out there on their own. They do have to make the calls. Fostering an environment where volunteers do feel safe to come to you. So as I was saying before, that can be for anything. That can be around something as simple as, hey, I'm not feeling well today. I don't think I should do this visit. We don't want volunteers to be visiting terminally ill patients if they're sick. So it's just, you know, making sure that those communication pathways are open, that they can say, yeah, look, I'm actually not feeling well. I can't do it. To anything from, yeah, it's really sad seeing this patient kind of getting sicker and sicker as time goes on, throughout the whole process of their, I guess, their time supporting the patient. A really important thing that has been extremely helpful for me is leaning on other members of my team here for the support and for their expertise. And that can also be across services as well. So, you know, support from volunteer coordinators at SAPs and NAPs, having support from Palliative SA and non-volunteering. It's all, it just makes us so much better at our jobs if we are able to lean on one another and get support from one another and support one another. So I just think that if you can if you ever, you know, if you're ever not sure about something, just put the call out to people, because it could just be something that's really simple. We don't all need to reinvent the wheel. Yeah, it can just be, I think, so important, because volunteer coordinators are usually quite solitary in their roles. There's usually only one of us, and we're like this little bit that sometimes doesn't quite fit into, you know, other areas of our service. So yeah, I think just being able to lean on other volunteer coordinators, as well as people within your own team. So I'm very lucky. I fall under the psychosocial team here at CAPS, so a lot of support from social workers, and that has just been incredibly helpful. Yeah, that's probably, that would be my little tidbits of advice.
Thank you, Jem. Appreciate that. Thank you for your time and sharing all your wonderful information, your knowledge, experience. As I mentioned in the introduction, today's session was an introduction about companionship and social supports, volunteering roles within that category. If you are a volunteer coordinator and would like more information about how to integrate these roles into your organisation, please visit our website at palliativecaresa.org.au/volunteeringsa/hub/. Our coordinator can support your organisation with training and tools to help establish these roles. If you are a volunteer and you would like to volunteer to support people at the end of life, please visit our website, palliativecaresa.org.au/volunteeringsa/hub/. Our coordinator can connect you to volunteer organisations who have palliative care volunteering roles available. And if you'd like to keep up to date with our project activities, please sign up to our free Palliative Care Volunteering SA e-news on our website. Thank you for watching, and we hope that you found this session valuable. Have a wonderful day.